Good morning, everyone, and welcome. My name is Jerry Iserman, and I am the Director of Clinical Support and Education at Teleflex. And on behalf of Teleflex, I want to thank you for joining us for the second in our Clinical Foundations webinar series, focusing on current evidence-based topics for the respiratory care professional. Following our presentation, we welcome your questions. Please enter those questions on the questions section of the GoToWebinar panel. You can enter your questions throughout the webinar. This webinar is accredited for 1 contact hour for respiratory therapists by the American Association for Respiratory Care and by the California Board of Nursing for 1 contact hour for nurses. The title of today's webinar is Protecting the Ventilated Patient from Hospital-Acquired Infections. Speaking on this very important and timely topic is David Vines. David is Associate Professor, Chair and Program Director, the Department of Respiratory Care at Rush University in Chicago, Illinois. His main research interests in the area of mechanical ventilation are the theory and application of modes of ventilation, positive end expiratory pressure, and ventilator graphics. He is the author of over 30 articles, abstracts, book chapters, and reviews, and has been invited to speak on respiratory care topics at facilities throughout the country. David has disclosed the following. Our speaker has disclosed the following: Anesthesia Respiratory Medical Advisory Board member, current research funding from Covidian, Iridian, South Medic, and Hollister. And this program is sponsored by Teleflex Medical. The AARC has approved this program for 1 contact hour of CRCE for respiratory therapists. Provider Sxing communication is approved by the California Board of Registered Nursing, provider number 14477. And the activity is approved for 1 contact hour for nurses. At the end of the webinar, you can obtain those continuing education credits by logging on to www.saxtesting.com/cf. Complete the post-test and evaluation form. Upon successful submission, you'll be able to print your certificate of completion. No off-label use of products will be discussed in this webinar. And now I'd like to turn it over to our guest speaker, Mr. David Vines.
Thank you very much, Jerry. I hope everyone's doing well out there today. And so I am sure that everyone on this webinar today has the same concerns that I do in our hospital here at Rush Medical Center in Chicago. So hopefully here today I will help clarify some things for you in regards to ventilator-associated pneumonia's definitions and where we're going to go down the line here with this ventilator-associated complications and infection-related ventilator-associated complications. So obviously that's a moving target right now, but I will do my best to let you know what I know at this point in time. And then we will also discuss some strategies here that have, and the research around preventing ventilator-associated pneumonias, and which are the hospital-acquired infections that I will be focusing on for most of the talk today. And so these slides, as we go through them, will have a lot of content on some of them. What I'm going to do for you is summarize the slides, hit the key components. If there's something on a slide you have a question about, just send us a question and Jerry will be glad to go through them and ask them in the end. So with that, we'll get started here in that hospital-acquired infections. There's your definition, right? That infection acquired in an acute care setting while receiving treatment, which I think we can all agree on. It's one of among the top 10 leading causes of death in the U.S. And the thing here that we all focus on is about 1/2 to 2/3 of these infections are preventable. So we have to do our part and use technology where we can to help prevent these hospital-acquired infections. So who's at risk, right? As with most things, right? The really young, the really old, those that are immunocompromised, our intensive care patients, and those factors that increase the risk or length of stay, the catheters, which are certainly and ventilators and ET2s, which are related to intensive care, complications from surgery, us not washing our hands, and then too much antibiotic use. Almost 75% of the hospital-acquired infections are associated with these four categories: surgical site infections, central lines, ventilator-associated infections, and then infections associated with urinary tract infections or urinary catheters. As you can see, there are listed the percentages on all of these and impacting hospital-acquired infections. And so surgical sites, here those surgical infections is around contamination of surgical equipment, inadequate surgical prep, and then healthcare workers and our not washing our hands and so forth. Certainly patients that have wounds, burns, or ulcers open themselves up to these hospital-acquired infections. Bloodstream infections occur due to the lines primarily. We have to have lines in these critically ill patients, and the longer the lines are in place, the greater the risk that the infections can occur. Ventilator-associated pneumonias, about 13% of all hospital-acquired infections. These occur obviously in mechanically ventilated patients, but the mortality rate's really high in this group, upwards of 50%. So what we feel is occurring here is that although this is called ventilator-associated pneumonia, and I've heard said in several meetings you've been in, really we should probably call this ET tube-associated pneumonia, because it's about the pooling of secretions in the back of the throat above the cuff, and if the cuff has folds in it, then they can drain down into the lungs, or it's about the biofilm that is created within the tube itself. And so the other avenue in which these can occur is through inhalation of aerosol products. So if you have a nebulizer that's contaminated, the aerosol particles are large enough to carry the bacteria with them that leads to the pneumonias. You could also have secretions that's pulled in the circuit that gets dumped back into the patient or into the nebulizer that causes the problem. And then again, if there's reflux from the patient up around the cuff that actually drains through into the lungs, then all of those things can certainly lead to our ventilator-associated pneumonias that we see. Now, I think everybody on the call is probably familiar with these definitions from the CDC for VAP that we've been using for years. And as you can see, right, we've all getting really good at trying to treat these and prevent them. And we even have a new category you don't usually see called the tracheal bronchitis, right? So there we give them enough antibiotics that we prevent them from having the infiltrate on the x-ray, and then, well, they don't have VAP. So they look like VAP, but not quite, because we don't always see the infiltrates changing there. So that's led to some of the new changes. And then I don't know how many of you use this clinical pulmonary infection score to diagnose VAP. Here, the score is sensitive but not specific to just VAP. So here's the part that's probably most interesting to you, and our chief of pulmonary, Robert Balk, was one of the groups that sat on this committee, the ACCP's representative, to actually help create these guidelines, and has been about the best source that I have to try to figure out what's going on. But even he will tell you that this is going to be under surveillance here for several years. And what they did was bring a group of experts in from around the country from various groups and associations to put together new definitions for ventilator-associated infections, or VAPs. So we will no longer report VAPs to, to nationally or be something that's tracked. So what's going to start being tracked through surveillance is going to be these ventilator-associated conditions, which is VACs, or this infection-related ventilator-associated complication. And so we're going to talk about how these work. So to even qualify to go under the surveillance or be reported nationally so that patients can look at this, you can be compared to other hospitals, and I am sure down the road lose reimbursement at some point in time. that you look at these for use in acute and long care hospital settings for patients who are 18 years of age or older that's been on mechanical ventilation for more than 3 days. And you can see all the rescue tactics that are listed there, like ECMO, HiFi. Those kind of patients are going to be excluded. Now, to actually qualify for a ventilator-associated condition here, you will have had to meet those criteria of being on the ventilator and having had your FiO2 or PEEP decreased 2 calendar days or greater and become stable. So you're decreasing. So if you started on 100 and you're now down to 50 and you stay there for 2 days and things look fine, then great. All of a sudden on the 3rd day, the required FiO2 requirement jumps up by 20%, or PEEP actually goes up by 3 centimeters of water above that baseline. And if it stays there for 2 calendar days, 48 hours, then you're going to get flagged as a VAC. Now, once you have a VAC, if on that 3rd calendar day and within the 2 calendar days before and after the onset of worsening of oxygenation, if there is an increase in temperature and or the white cell count is elevated, and you start a new antibiotic, then you're going to get flagged as an infection-related ventilator-associated complication. Now, the question comes right now, these are manually reporting. We're manually reporting these in our hospitals. I am sure you are manually reporting these in your hospital too. And so down the road, though, I really think that this is going to be pulled over electronic medical records. And what will ultimately happen is you're going to chart it in the computer, and then the computer is going to flag them through the electronic means and surveillance tools that they will have installed, and it's going to tell them immediately whenever you hit them, so that, you know, I guess you could lie in your charting ultimately to get around it, but that's most likely what's going to happen there with that in the long run. So those are the new definitions and where it looks like where we're headed there in the future. Just to review here real quick about the impact on the clinical outcomes and cost of care related to hospital-acquired infections. This slide really tells you a lot. If you look at this table that you're looking at, you can see that we almost spend $20 billion a year on these hospital-acquired infections, which just really drives home the point of what we must do to try to prevent them, and needing some new technology. I don't think it's possible to completely eliminate VAP, probably surgical site infections, all of those things, but we certainly have to get a handle on it and reduce the occurrence that we have right now. We cannot have almost 100,000 people a year dying from hospital-acquired infections. And so things like coatings for catheters to help prevent infections needs to be developed and explored. Things here around making sure that we are vigilant in hand washing and prepping of surgical sites, and what we can do today will focus on what we can do to prevent VAP, but these things are costly to the medical center and other hospitals. If you look at what it says cost per infection here on this list, I'm sure many of the respiratory therapists and probably nurses and other people on this call have been told that a VAP costs the hospital $40,000, $60,000, and you can see here, well, that slide says 10. Other studies will say 12. Just so everybody is clear on what's on this slide, those are actual costs, right? Those are actual costs to the hospital, not the estimated billed costs. That's what it's actually costing you per patient on average, some more, some less, of course. And so the question is, when is Medicare, Medicaid going to stop paying for these complications? And I don't know if anyone's on the call that wants to send over whether or not they've had already a denial for a VAP. But not long ago, I was delivering a lecture in Tallahassee, Florida, and one of the hospitals there had already had their first VAP case denied for funding to pay for them. So we've been told that, well, they're not going to do this, but that may already be a reality. Certainly surgical site infections, catheter-based UTIs, bloodstream infections, all of those are already should have had payments stopped for. And all of this is placing growing demands on the system where we all are aware of current reimbursement changes that are going on and the monitoring for our value-added care and how important quality is, and then patient satisfaction scores. So for the rest of this talk that we have here, the next 35 minutes or so, I want to focus on some strategies to help minimize these hospital-associated infections or risk of them, certainly around those in mechanically ventilated patients related to ventilator-associated pneumonia. And so we're going to focus here. You can see this list that we're going to go through, quite a bit of things here that we can do, and I'm sure many of you are scanning that list going right now, is that in my bundle, is that in my bundle? And we'll talk about some of those things later on. But I can tell you that in around the approach, it needs to be evidence-based, right? We need an evidence-based approach to trying to prevent VAP, and it needs to be multifactorial, meaning that we need to come at it from multiple directions. It's probably not one single thing that's going to ultimately reduce it overall. It is truly the bundle of things around the whole aspect of care. And even here around length of stay in ICUs and so forth. If you think about it, this even relates to whether or not they leave in a central line longer than you actually need it and pull the central line earlier, because obviously if they get sepsis from a central line, they're going to be on the ventilator a lot longer. All of these things are very much related. So you can see the predictors listed there for ventilator-associated pneumonia. I don't think there's any surprises in that list that you're looking at for the group on the phone. And then certainly we want to be able to avoid risk associated with airborne or liquid-borne contamination, and HMEs, or whether we filter those HMEs. Right now the CDC has no guidelines for prevention of the hospital-associated pneumonia. Here is around the use of HMEs, whether that's superior to active and heated humidification. So not one way or the other. I'm not saying you should be using one or you should be. So we're going to talk about some of both here today. The first thing I want to talk about is appropriate pulmonary hygiene and conditioning of gas. Certainly I have seen, and as I've given lectures throughout the country at state meetings, national meetings, and asked this question, I find a lot of times that patients, I'm not convinced we're doing a good job adequately humidifying them. And all of these mechanical ventilated patients, if you look at this, we naturally condition gas that we inspire and then we exhale. So on inspiration, one could see here that if you put someone on a mask, obviously you don't need as high a temperature or as high of relative humidity compared to if it enters the trachea, where you can see it should be around 33 degrees Celsius and 100% relative humidity. So we get in these discussions, and by the time it's about actually 4 centimeters, you can see that isothermic saturation point is much lower in the lung on this graph than what it probably is, or this figure. It's probably about 4 centimeters or so below the carina. And at that point, it should be about 37 degrees, 100% relative humidity, or the 44 milligrams of water per liter. If it's coming into the trachea, that 33, at least 33 degrees Celsius, and that 35, 36 milligrams of water appears adequate. We certainly don't want to over-condition a gas. I would tell you, and never give them more than you wouldn't want to give them more than the 44 milligrams of water. So something we should also be cautious of, because you could actually liquefy secretions too much, or it could be an irritant producing more secretions that could end up causing, could potentially lead to other complications there. So when we're conditioning gas, we're going to focus here just a minute and talk on this, right? If you don't provide as much humidity as needed by the body, which is that 44 milligrams of water, you cause a humidity deficit. And if you cause a large humidity deficit, then you shift that isothermic saturation boundary deeper in your lung. I can remember when I first moved to Chicago, and I'm sure you can tell on my voice that I'm a Southern boy, that I grew up in the South, Louisiana, then spent some time in San Antonio. Well, Louisiana is very humid. I moved to Chicago here to Rush about 3 years ago, and we started an entry-level master's respiratory care program. And with here, you know, I like to run, so I was out going for a run and thought I was going to hop out there and go run in 30-degree weather one day. By the time I got back, my lungs were killing me because the air was so dry. I had nothing over my mouth, breathing this very cold, dry air, and it shifted my saturation boundary. So, you know, if we create these types of humidity deficits, and in the ICUs, all we give is dry, cold gas. Oxygen air, even the air, if it comes out from a humid, is ran through an evaporator and dried before it ever hits a line so they don't fill with water. So high minute volumes breathing these cold airs certainly will cause humidity deficits. Deficits lead to destruction of cilia, sloughing of the cells, of the squamous cells, inflammation, and then you have this thick mucus viscosity that occurs. So minimum here, we need at least 30 milligrams of water per liter is what estimated, and you can achieve that through whether you're giving passive or active humidification. I like to use this little diagram to help guide us here on what is, you know, what should we really be doing. And you can certainly use HME as long as you see up there at the top where the little asterisk is, as long as you see that there's none of those complications present, then one can certainly use an HME, and we'll talk more about that in just a minute, and try to deliver that 30 to 33 milligrams of water per liter. If they're not there, or you can't do that, or the secretions are thick, then you probably need to push the humidification up a little bit to make sure that you're providing them adequate humidification through the ventilator. And I will tell you the way that I think you need to do that is look for rain out in the ET tube. Whenever you think about the other part of that is they also need adequate systemic hydration. That may be the best way of actually liquefying those secretions. So the problem occurs here with the circuits that we use. So if we look at this diagram, and we can see that we have in this limb here, right, if we have heated wire circuits that we're using, then the temperature is being measured right here, right before the Y of the circuit. If you look back over here at the heater itself, then the heater, once you have these heated wires, let's just say that this wire you have on this particular heater, 3 suns, and the heater temperature here is set on 37. That means the heater is actually warming to 34 degrees Celsius, and then it's going to continue to warm that gas on the way to the patient then. So as it warms the gas on the way to the patient, that's meant to prevent rain out. But your basic absolute humidity from that heater is still going to be related to the temperature around 34 degrees Celsius. And so with that, that's the water that you're delivering. So if you actually have that and you're still seeing rain out along this tube, then you know your gas has to be cooling to less than 34 degrees Celsius to actually see rain out along the tube. So what I'm going to tell you is that once it hits this point, which I didn't realize till I did a bench study here a couple of years ago, that once it leaves this temp probe at this point, it heads to the ET tube, that gas cools rather quickly. I mean, it almost drops a degree per centimeter of water depending on flows and other settings and so forth, but it cools anywhere from 3 to 5 degrees Celsius. So if you have the difference gradient is only 3 and you're not seeing rain out in the ET tube, you're not adequately conditioning the gas. We don't want the rain out necessarily in the circuit, but I'm going to tell you the only way you know you have 100% relative humidity is to find the rain out in the ET tube, and you need to adjust the heater settings to where you achieve that goal. An easy way may be to set it on 36 and 1 sun. If you don't see rain out, go 37 and 2 suns, and then if you don't see it, you go 38 and 3 suns, so your heater stays 35, and then ultimately you're holding more water, and you should start to see rain out in there. If along the way the whole circuit's dry, then leave it on 38 and go, or 39 and go back to 2 suns, go back to 1 sun, which will increase then the absolute humidity until you get rain out in the circuit and the ET2. Those things are what we all should be doing. We should be noting in the medical record that we actually have adequate humidity delivering to a patient, not just a temperature, because a temperature tells you nothing unless there's rain out in the ET2. Okay, so I'll get off my soapbox now, sorry. If you look at conditions affecting the humidity, we all know temperature in the room, higher minute volumes, varies peak flows, along these things. But the thing, if you look at Lafush's study here in 2004, actually some ventilators that have higher temperatures at the outlet will actually affect the humidifier's ability to adequately condition the gas. So I'm going to tell you in those situations, you need to be observant. Again, you have this gas you think is being humidified, but you look at the circuit and it's dry and the ET tube's dry, then you need to turn the temp up coming from the device. Because if you put a hot gas into the heater goes, the gas is already hot. I don't have to warm it up. So it will back off and won't put as much humidity in it as is needed. Okay, so filtration. Yes, we should be filtering the gas going and coming from the ventilator. That should be occurring whenever we use these devices on any of the patients, whether it's in the ICU or whether it is in the OR. And the other thing to pay attention to here, this 2009 study by Lafush out of France, is that not all HMEs are created the same. So when you go to buy an HME, I will tell you that usually, you've got to make a decision on, is that HME going to adequately humidify my patient? I'm not going to tell you to go buy the most expensive HME, but I can tell you the cheapest HMEs probably will not be adequate for long-term mechanical ventilation in most patients. So you need to look at the data around the HME, and I would tell you too, you need to be able to see condensation from the HME when it's on the patient in the conditions that they're being ventilated at. If not, then perhaps the humidification is not enough from the HME and you switch to active humidification. So obviously tidal volumes affect it, larger tidal volumes, smaller tidal volumes, FiO2 concentrations. Ideally, we want something affordable, light, adds minimal dead space to the circuit, and causes minimal resistance. Well, somewhat it's a give and take in that, because actually the ones that hold more water usually have a slightly more resistance because of the material that they have to use to make them out of. The other thing we want to be able to do when we're using these products is really, we don't want to have to interrupt the circuit if you can help it. Every time you break or manipulate an ET tube, then you potentially adjusting that up and down, you could cause secretions to drain around the cuff. And so, or you could have circuit contaminated. And so these HMEs that will allow you to deliver aerosol through them without having to break the circuit adds multiple benefits here, as you can see on the slides. And so if you can, I would suggest that you look into those types of HMEs, certainly around trying to prevent VEP. HMEs here also, there's some list of contraindications. So if your patients have these contraindications, they should not, in my opinion, these are from our clinical practice guidelines at the American Association for Respiratory Care, should not be on an HME, shouldn't be put on an HME to start. They should be on active humidity and adjust active humidity to get the rain out in the ET tube. And once you do have them on an HME, you got to stop and go, okay, do I have these signs? Or does the patient have accessory muscle use? Is the patient forcing exhalations due to the resistance? And assess them to make sure that they're pulling and triggering the ventilator with their efforts like they're supposed to be, that they're exhaling passively and not having to force them there. And certainly you can compare peak pressures from the ventilator pre and post changes and be able to determine if there is an influence from the resistance on the patients. Now, the other thing is, how frequently do you change them? Well, depending on how expensive your HME is, it wouldn't take long to cost you a lot more than the circuit and the water. So, this is where you have to make a decision. Do I have a 24-hour patient that's only going to be in the vent, or post-op heart I'm going to wake up and wean off in 4 hours? But if they're coughing up blood and secretions into the HME, then you're going to obviously switch to active humidification, because the cost would certainly be lower there. Most manufacturers recommend changing HMEs daily. There are, though, HMEs out there that will run for 72 hours without having to be changed. So again, the less you have to break the circuit and can use an HME for a longer period of time without having to change them in and out, perhaps there is a benefit there, not only in cost but also in reduction of risk of ventilator-associated pneumonia. And you do want to avoid manipulating ET tubes, and non-essential suctioning is another way that you would do this, or aerosol devices that you don't have to break the circuit for. So if you're having to take aerosol devices in and out of a circuit, you're just increasing the risk here for potential contamination. And then anytime you're suctioning someone, and we could get into the debate of, do you use saline, do you not use saline? Our current clinical practice guidelines say you don't use saline if secretions are thin enough to come up the tubes on their own. So if the secretions are thick, though, and can't come up the suction catheter, then you have to use saline in those practices. Here's looking at this study, right, and the circuit changes listed here. We do not routinely change circuits for infection control reasons. So there is some benefits in trying to identify product that will let you use them for the life of the mechanical ventilation, not just due to manufacturer recommended settings of 7 days I'm going to change a circuit. So, this is where clearly been shown that you do not change circuits and manipulate ET tubes for infection control reasons unless they are soiled with blood, secretions, so forth there. So a part of a multifaceted study here, looking at putting several of these together, one thing was non-essential suctioning, not routinely suctioning patients just to make a pass. Now, I can tell you right now, this is something that as a clinician I've had issues with. Are you kidding me? I'm going to go 8 hours and not pass a suction catheter? Are you so kidding? And so the reality here, though, is that we got to check ourselves, because the data here looks like that if they don't have secretions, you can't hear the secretions, can't see them, you listen to the patient, you can't hear the rhonchi, then why are you passing the suction catheter? You're just inducing more risk, and potentially in this of manipulating the circuit when you're suctioning them and so forth. The other part of that is that actually the vacuum itself, if you don't include the set, the vacuum itself, if it's set on full wall vac, can suck the volume out of the lungs. I have some studies we were doing on swines that showed the pleural pressures on those swines, measuring esophageal pressures, went as low as a negative 35s, negative 40s on them doing suctioning on full wall vac. So it's not without risk, and if you suck that hard on the lung, just imagine what you can pull around the tube. And that was only in a 10, 20-second suction. So it happens a lot quicker, I think, than we realize as clinicians sometimes. Now, maintaining cuff pressures. Essential that we maintain cuff pressures greater than 20. Almost all the guidelines you will see this written in, that you maintain cuff pressures. Not minimum leak technique, minimum occluding volume perhaps, but I would even tell you now it's better to measure the cuffs, put them at 20. Really, that's actually low. You could even be as much as 25 or so. And the basis of that, I'm sure everybody knows, right, is capillary blood flow somewhere greater than 25 millimeters of mercury. Well, 25 millimeters of mercury is not 20 centimeters of water. It's not 25 centimeters of water. It's about 30 centimeters of water. So that's where we as therapists always set cuff pressures between 20 and 25 centimeters of water here. We certainly don't want excess pressure, so this is something we should be monitoring to try to prevent the pool secretions from draining into the back of the lungs. Now, it is in the guidelines, as you can see there, but even an automatic randomized control trial compared to checking at routine care, you could see that using a piece of equipment to try to maintain cuff pressures at 20 was not better than therapists or the nurses maintaining cuff pressures that are targeted. Okay, so let's talk a little bit here about ETT modifications. And there's a lot out there, right? And this is something that can be very expensive to a hospital and purchasing those in some designs. So in a meta-analysis, it does appear that it is beneficial that using the subglottic secretion drainage, it will prevent VAP. Now, I can tell you now, I would love to see them compare this to a bundle, because I think a lot of them, if there is a VAP rate that's occurring and the only thing you do is modify the subglottic suctioning and add that, then yes, there's going to be a benefit there. The reality of that is it probably needs to be back compared to the bundle. So this is one of the barriers right now to use is cost and which patients need it. Some of those tubes are outrageous. There are others out there that are much more cost effective in implementation, but some of those are extremely expensive when you compare $3 to $18 a tube whenever you go to use these tubes. So these are the things right now that are really holding us up on when do we use the tubes, which patients should get them. Certainly I don't want to spend that much money on a patient that is only going to be on the vent 3 days. So if you had a device where that you could add on or so forth, the subglottic suctioning, that could be beneficial as long as you can keep flow through the tube compared to every tube having the subglottic suctioning and costing the increased cost in them. Maybe we put them on everybody that looks like they're going to be 48, 72, so forth hours. And so some of the concerns here, the thicker tubes, more rigid, right? There's been report of laryngeal nerve damage from them. There's also some herniation of tissue into the little suction itself or into the channel within the port or the suction channel on the ET tubes, right? And so these become some concerns, and right now those are the things that have to be overcome in dealing with these tubes and whether we put and use them in the future. Now, there are several new cuff designs out there that certainly appear beneficial. These new cuff designs that will actually prevent the folds in the cuffs or be able to catch the secretion so they don't drain into the lungs is certainly spikes everyone's interest here in trying to prevent those secretions from draining from the oral pharynx down into the lungs. And so, you know, this is something that certainly will be increased use, I think, here in the future. Now, what about the prevention of the biofilm within the tube? So this tube of the silver-coated tubes are extremely expensive, and effective that they actually reduce the VAP rate or the growth. There's also other concerns that the biofilm within the tubes that grow actually narrow the tube, increasing the patient's resistance to breathe, maybe prolonging mechanical ventilation. So there are various devices out there, though, that could be used to clear the tube. There are that are certainly far cheaper in patients that are ventilated longer than putting silver-coated tubes in everyone, which right now that technology is just cost prohibitive of trying to put these $30 tubes in everybody you intubate within the hospital. And so I think that's really where we're looking at next here is the cost effectiveness of those in which patients need them or not. Now the thing all of us, and I am sure in your facility just like mine, boy, the increase in monitoring now through hand hygiene, glove and gown adherence is off the charts. Everybody's doing it, everybody's monitoring, everybody's reporting it. And so I think that is great. This is something that we all have to do. You walk in our facility and you will see a sign that says protect your patients, make sure you wash, gown, and glove. So, and there's patients who are reminding people that are reminding you before you walk in a room, wash your hands, wash your hands. So I am sure our patients are very aware of, because they can see all these signs, they're not hidden, that that as healthcare providers we need to be washing our hands before we touch them. And so we need to keep that in mind. Now you could certainly do some things like placing labels on ventilators, signs in rooms to help remind therapists and nurses and other clinicians, physicians, all these individuals that, hey, you need to be washing your hands before you enter and leave that room. Elevating the head of bed. So elevation of head of bed to 30 to 45 degrees, there's certainly, as you can see, it's a high level of recommendation. Level 1 recommendation in the guidelines there to prevent VAP. And then like clinicians, though, we have a really hard time keeping this head of bed elevated. Anywhere from 50 to 86% you see that of us cannot correctly identify a head of bed elevation. So you look across this, I was shocked to see in this little study that respiratory therapists, I think it's due to all of the bronchial hygiene they do in CPT and prostral drainage, actually can identify the head of the bed fairly well. But they make markers that easily go on beds, right, that you can hang down to know, hey, here's the little green area, you go here, you're in red, and so forth. And most of our beds have been equipped with those type of modifications to make sure individuals know the head of bed is elevated. And you can go, okay, what about these patients where they have to be flat? Well, perhaps those patients are the ones in the subglottic tubes that you ought to be thinking about putting those type devices in them, because those kind of patients then would be at an increased risk of aspiration of oral secretions. Okay, oral hygiene. I thought this was a pretty done deal. Everybody gets oral hygiene. High recommendations. We brush their teeth, clean their mouth. Makes sense to me. Use the chlorhexidine, reduce the bacterial colonization that's there, and ultimately reduce the VAP, which has been recommended and shown in studies. But I was listening to a talk at the critical care medicine here the other day in Puerto Rico, and there was someone questioning whether oral hygiene is effective as we think it is. So I'm sure most of us, though, or as we are, doing this at least 4 times a day, using the chlorhexidine, this 0.12% solution, and brushing the teeth and washing the mouth and cleaning out the pool secretions that are in back of these patients' throat. Again, I believe that this is effective, and our RTs help the nurses with this work. Now, the other thing which is clear is keep the ET tube out, you reduce VAP. Get rid of the ET tube, you reduce the pneumonias. So non-invasive ventilation is certainly on the rise. We need to get better at the way we use masks and mask designs and interfaces and using them. COPD patients should never be intubated until they go on these non-invasive devices. Certainly if their pH is 7.25 or higher, they should at least get a trial of non-invasive ventilation. That's pretty much standard of care. And as you can see in the surveillance study, look at the reduced number of pneumonias associated in the cases. Not quite the same cases, but here the rate is actually lower in non-invasive ventilation than those in mechanical ventilation. Okay, the other thing, this assessment of daily spontaneous breathing trials. These awake sedations and spontaneous breathing trials should be occurring simultaneously so that we're waking patients up. We here usually do them in the mornings, and you can look at the slides and see all the ones in white and the significant differences that are showing up in length of stays, reduced mortalities, right? And so in these patients, we need to be waking them up, and some places have even started waking them up not just in the mornings like we're doing at 5, 6 a.m. They're waking them up when they wean down, meet the minimum ventilator settings, waking them up and doing spontaneous breathing trials sooner to get them off the ventilators. Now, all of us should be following our infection control practices, disinfecting appropriately equipment that's been in the room, and so forth. So I'm not going to get too much into this except make sure that you're wiping those ventilators down and equipment that you're using coming in and out of the room, and depending on what it's exposed to, following appropriate infection control here. The adherence to that is really the most important thing that we can possibly do here. And then our own, when we're suctioning patients, make sure you're using sterile techniques. If you're not using closed systems, you're just inducing bacteria into a lung then that could potentially cause pneumonias. Bundles. Everybody, I'm sure, on this conference call is using a bundle. They are effective in reducing VAP, have been shown to be effective. Part of this 5 Million Lives campaign, and here's a list of some of the essential things that comprises bundles that you can see the references there. Typically used, had a bell elevated, these sedation vacations with spontaneous breathing trials occurring, prophylaxis here for deep vein thrombosis, ulcers, and then the oral care pieces. So in conclusion, today of the things we're talking about, certainly hospital-acquired infections have a huge impact not only on cost but lives of our patients. And here in the future, with our new definitions of ventilator-associated complications and infection-related ventilator-associated complications here, tracking these and trying to prevent those, not having your facilities flagged with these higher rates, is something we have to take an active role, in my opinion, of trying to prevent here. I also don't believe it's possible to have a zero rate of VAP. I think it will occur. I think they will have to establish some kind of minimum rate over time on these lengthy mechanically ventilated patients. Certainly glove, hand hygiene, glove, gown, we need to be doing that. Head of bed up, providing oral care, using non-invasive ventilation as much as we can, maintaining appropriate cuff pressures, and then avoiding manipulation of the ET tube and breaking the circuit. And you can see a whole list of things there that could potentially help with that. You don't just have to use MDIs. You could certainly use nebulizers that you don't have to remove from the circuit. Avoid routine suctioning. Try not to change circuits. Use HMEs that can be used for longer than 24 hours. And with that, I thank you for your attention very much, and I'll be glad to take any questions that you have.
Thank you so much, David. At the end of the webinar, all of you that are participating can obtain your one contact hour, both nurses and respiratory therapists, by going to www.saxtesting.com/CF. Complete the post-test and evaluation form, and upon successful submission, you can print your certificate of completion. I'd like to now open the debate for questions. And David, we've had so many questions come in that we'll only be able to handle a few in the remaining time, but we will post answers to those we can't get to on the website. The first question has to do with circuit changes, and this question is as follows. Our circuits have a red manufacturer label that states to change every 7 days. If studies show they are to remain on for the length of stay or until soiled, how do we get around that label? Ripping it off would look suspicious and may prompt JCAHO to investigate our practices.
Yeah, so the reason for that was that there was a issue with that particular circuit that requires the manufacturer to put that label on there. So if you choose to use that circuit longer than 7 days, you're taking that liability on as a facility. So I would tell you that not all products require a 7-day limit, and perhaps you should look at other products, and I really won't say more about that than that within the seminar.
Thanks, David. The next question is interesting because it deals with long-term mechanically ventilated patients. And the question is, are the guidelines you've talked about applied also to these long-term mechanical ventilated patients? By that she means ventilated for months and years with a tracheostomy tube?
I think that the home health group, it will be different, it appears, is my understanding, but the LTACs are included in those definitions. So LTACs are long-term acute care facilities, and the ventilator patients they take care of will fall into those same criteria, is my current understanding. So you should be having those monitored by your facility now, and we will see what ultimately comes out after they do, I believe, 2 years of surveillance. They're going to do 2 or 3 years of surveillance and then have some clear drawn requirements of what you have to meet.
The next question is related to manipulation of the endotracheal tube, and the participant would like to know if that also applies to changing the tube from side to side to prevent skin breakdown.
You know, you don't have a choice there, unfortunately, but I would recommend to you, before you do that, perhaps you even do the oral care first. Suction out the mouth, clean the mouth with the oral care so that you kind of decontaminate it. Take that suction device and try to get down below the cuff, above the cuff in the back of the throat, and then move the ET tube right after you do it. Don't move the ET tube first, full of secretions in the mouth that have not been decontaminated. Is the thing that I would recommend for you in practice.
Thank you. The next question is related to HMEs. We have found that as the HME becomes saturated, the resistance gets higher. What have you seen as far as pressure going up when an HME is used for more than 24 hours?
Well, I think, again, that's going to depend on the HME that you're using, so I'm not sure what brand of HME you're using. We use HMEs less. So we do use some HMEs, certainly in our short-term ventilated patients. We use mostly active humidity, and our goal really is to adjust the active humidity, or adjust, yes, so that we get rain out in the ET tube.
Excellent, thank you. Do you think that most hospitals are aware of the new CDC, NHSN surveillance information, and how could we best make the information known to our hospital?
I don't know that, I'm not sure how aware the staff are of those new guidelines and recommendations for definitions for surveillance here and ventilator-associated conditions. I'm absolutely certain, though, I believe that all the hospitals have been contacted at this point about what those new definitions are, because I think they're already required to report them as of January. So as of January, is my understanding, they are now being reported, and so in being monitored, data is being collected. So that's the, and so how do we improve? I think things like Teleflex did today to help clinicians understand these definitions and have discussions with them, and have discussions with your infection control department here are really the steps in moving that information forward.
Thank you.
I would suggest that in state meetings too, I would suggest that they also have someone lecture on these topics at state meetings, national meetings, things like that in your own professions.
And the next question has to do with lavage. Is using normal saline solution pre-suctioning a good or a bad idea?
Well, the recommendations are that it is a bad idea if the secretions will come up the catheter on their own. So if the secretions are thin and they come up the ET tube, then using saline is not necessary. Now, as all clinicians, and I am sure of the, 14, 15, 16, 1,700 people on these conferences here listening today, just like me, have had patients that we put saline down with an ambu bag and bagged that we couldn't get secretions up and the plug comes out. So, those though are secretions that will not come up an ET tube very well on their own without the saline. And as we know, saline does not break the secretion bonds. Maybe it helps loosen them up and hydrating them to move up the catheter. But that otherwise, unless it's thick secretions that won't come up the tube, then that's when you would use saline. But again, I'm going to tell you that if you're having a lot of thick secretions, you need to look at how you're doing humidification, and you need to look at how you're hydrating those patients, whether it's neonatal, adult, pediatrics.
Thank you, David. And we have time for just one more question, and that is, what department and what method are you going to use to track this? Manual tracking or electronic tracking?
Oh, that's a very interesting question. So I am right now looking at tools. Right now we are manually tracking, but I am looking at tools right now to eliminate the need for manual tracking. I am looking at a device that actually will take information from the ventilator, even medical record, and will go to a smartphone or a tablet and alert the therapist that, hey, you are 24 hours on a 20% increase in oxygen. Is that needed? So that they can actually wean the patients down that do not need the oxygen or adjust the PEEP back down. So there are companies out there actively involved in creating these devices. But I can tell you it has to be almost real time in monitoring them and provide these feedback. I think that therapists and nurses, everybody is involved in patient care. We need to use technology to create these reminders, and having something that can take this information from multiple sources, reorganize that information, that data for you, and present it in a usable manner as a reminder is really where the future's going.
Thank you so much, David. We very much appreciate your insight on this very interesting topic. And now just a few housekeeping details for all of you that attended the webinar. And David, is there one more slide? There it is. I want you all to know that this webinar will be archived on www.clinicalfoundations.org in 7 to 10 days. A PDF of David's slides will also be available to download at that time. And one other thing, you will receive an automated email 1 hour after this webinar with all of these details. So in case you didn't get to write everything down, not to worry, you'll receive all the information via an email. Once again, thank you one and all for joining us for our webinar today.
Yes, thank you very much.